uh, while we talk about this topic, and I'll try and focus my thoughts on patients, oncology patients. And I'll talk about old drugs and new treatments. So I'm delighted to be with you. Some of you are going to know me. I've spent 35 years studying, teaching, and consulting on treating patients with infectious diseases. It's been a lifelong passion. I was going to speak for about 35, 40 minutes. I'm delighted if you would have any questions or comments. You can chat, put them in the chat box, or eventually you can unmute and ask questions at the end. It'd be wonderful if we had a bit of a discussion. I'm also told that this presentation is being recorded, and as well, you will have access to the PDF slide. So I don't really want you to take notes. I want you to have a little bit of fun. What I was planning to do was two things. So for those of you who want to take a nap, 35-minute nap, let me summarize. My summary will be that number one, we have very little data on patients with malignancies in terms of skin and skin structure, in terms of guidelines for treatment. What we typically do is we just lump these patients in with everybody else and put them in the general guideline category. I know it's terrible, but that's what happens. And being involved in these guidelines, that's what we've done. In terms of studying old drugs and new drugs, we need way more data in specifically your patients with malignancies, in terms of treating skin and soft tissue infections. When we study new antimicrobials and how to treat ABSSSI infections, we don't really think that much about patients with malignancies. And as you know, at times in clinical trials, these patients are actually excluded from clinical trials. So we need a lot more data. And some of what we talk about is pretty general, and I know you don't like that. You'd like more specifics about your patients. So let's have a little bit of fun together. So my disclosures, Vicky said, one of my jobs is I'm the research director of this group called CARA, and we're interested in infections in your patients that are caused by resistant pathogens, and we do a whole bunch of things, including treatment and prevention. This is our website, www.can-r.com. And these are my disclosures. I've spent 35 years treating infections in all types of patients, and we work with every antibiotic you use in your practice, and we work with every single antibiotic you will use in your practice over the next 1 to 5 years. So these are my research funding conflicts. I also have to disclose that this event is being sponsored by Paladin, but I want you to know all the slides were put together by me. So my objectives. I'll briefly talk about the current treatment of moderate to severely ill patients with ABSSSI, again, acute bacterial skin and structure infections. Then I'll talk about some of our challenges of where we are with treatment. And then I'll spend some time with you talking about new antimicrobials, and specifically an antibiotic that has just come out in Canada that we have never seen in my 35 years. This is an antibiotic where you give one injection and your patient's infection is treated. So in my 35 years, we've never had an antibiotic where you give one dose and your skin soft tissue is treated. And I will focus on that because it has some potential to be used in infectious diseases, but potentially other specialties such as oncology experts as yourself. I think you'll find this fascinating, but there are also some antimicrobial stewardship challenges here that we need to talk about, like we do with all new antimicrobials. And I'll talk about the clinical data and the potential usage in Canada in your patients. So let me start with current treatment. We do not have the most current guidelines. They're just being revised. These are the American guidelines for treating skin soft tissue infections. And I don't want you to fall asleep on me. It's pretty simple. On the right side, we talk about purulent infections. Those are all the pus-forming infections. And what we talk about here is that if you have mild infection, basically you don't do much, moderate incision and drainage, culture and susceptibility, and you treat orally. And the severe is incision, drainage, culture and susceptibility, and you're using intravenous agents. and in your practice, a lot of intravenous vancomycin. You probably don't use that much daptomycin or linezolid, but you may use a little bit. Purulent infections, I want you to think, are primarily staphylococcal infections, Staphylococcal aureus, and we worry about MRSA. In your patients, when they're sick, you also have to think about gram-negative bacilli like E. coli and Klebsiella and even Pseudomonas, and I'll talk more about this. But if you've got a culture and it's a gram-positive, it's likely Staphylococcus, but it could be Streptococcus. On the left side of the graph are the non-purulent. These are the cellulitis. This is more of a streptococcal disease, but it could also be Staph aureus and MRSA. But in your practice, you also have to be thinking about gram-negative bacilli, such as E. coli, Klebsiella, and Pseudomonas. So typically, if you look at non-purulent, moderately ill, we're treating with a penicillin or a cephalosporin or maybe clindamycin to cover strep, but also staph. But in patients who are sick, you're using combination coverage. And in your patients, if you've got someone sick, they've got a malignancy and you're worried that they're immunocompromised, you're covering staphylococci, streptococci, which means intravenous vancomycin. But you have to be adding on gram-negative activity, piperacillin, tazobactam, meropenem, ceftriaxone, some of these agents, whichever of those you prefer in your practice. So it's a staphylococcal disease or a streptococcal disease, but for you, gram-negatives are important as well. So let me show you some Canadian data. We've been studying wound infections, skin soft tissue infections in patients, including your patients in Canada for many years. This is data from the CAN Ward study, and I'll show you some data from this study, which is a national study where we study the types of pathogens that cause infections in patients affiliated with Canadian hospitals. And I'll take some of the data from this paper we published as part of a supplement. We looked at 43,000 pathogens causing infections in Canadian hospitals, including patients with a variety of malignancies. And this is the slide I want to show you. This is Canadian data, including in patients from Ontario, including from Sunnybrook. And what we're talking about here are pathogens causing wound infections or skin and skin soft tissue infections. I've yellowed out the gram positives. And I want you to remember that in all your patients, you have to be worried about the gram-positive Staphylococcus aureus, which includes MRSA, but you have to also worry about the streptococci, such as group A and group B strep. I didn't yellow out, I put in white the gram-negatives. In your patients, if you've got a patient with a malignancy, you cannot only treat against the gram-negatives, such as with intravenous vancomycin or daptomycin or linezolid. You have to empirically cover gram-negatives, such as Pseudomonas, E. coli, Klebsiella. So you're adding in agents like piptazo, ceftriaxone, meropenem, levofloxacin, whatever gram-negative agent that you like. Then ideally you get a culture, and then you de-escalate to directed therapy against that pathogen. But I want you to remember these pathogens, staphylococci and streptococci, and in your patients, you also have to cover against the gram-negatives. So let's talk about some current challenges. This is Canadian data, and what I'm talking about here is if you're treating ABSSSI in patients who are moderately, severely ill, and you're using intravenous therapy, vancomycin is your workhorse, and you've all used a lot of vancomycin. It's not a great drug, has some toxicity, but it's been around forever, and it's still the standard of care in most guidelines. Daptomycin is a available safe agent. Linezolid, IV or oral. No one in Canada uses telavancin. Ceftobiprole is an agent that we've studied for many years. It is used primarily in Canada by infectious diseases specialist to treat bacteremia and endocarditis. And then there's dalbavancin, which I'll talk about, which is a brand new drug that just came out in the market in Canada. Oral agents you've used extensively: cephalexin or Keflex, cloxacillin, clindamycin, doxy, linezolid, and triamsulfa. The agents with the stars also have activity against MRSA. And as I talked about, and that's on the right side, in your patients, I think the big difference is when you're worried that your patient is immunocompromised, you have to add in coverage for gram-negative bacilli as well. Ideally get a culture, then de-escalate to directed therapy. But commonly used agents for gram-negative activity in Canada, Pibtazo is the workhorse. A lot of you love ceftriaxone, still a very good drug. A carbapenem like meropenem or ertapenem, very, very good agents. If you want to use a quinolone like levofloxacin, ciprofloxacin, there are other alternatives. So what are the other aspects that we have to think about? And that is, where is the patient? If you're treating the patient in an outpatient clinic, typically you're going to be treating, maybe you're going to give them a dose or two of IV, but you're treating orally. So you're using a lot of cephalexin and cloxacillin, clindamycin, doxycycline, safe, relatively safe antibiotics that cover staphylococci, cover streptococci. Some of them like doxycycline, triamsulfa will also cover MRSA. Ideally, you have a culture to exclude the gram-negatives and rule in a Staph aureus or a streptococcus. If you're seeing these patients in urgent care or emerge potentially as a consult, these patients are moderately to severely ill. Typically, as you know, emerge dogs love these days to give a dose or two of IV, perhaps get a consult from you in terms of what you think that you want to do. And then you have to make a decision. Are you going to keep that patient in the observational unit, give them a day or two or three of IV? Are you going to admit them to the ward? Are you going to give them a dose or two of IV, put them on oral and discharge them? Are you going to refer them to the outpatient antimicrobial therapy program to give them IV? Or what are you going to do? And then in terms of hospitalized patients, these days, patients who are hospitalized are typically quite severely ill. It's IV antibiotics. We don't give oral if you're sick enough to be hospitalized. If you're sick, if you can have oral antibiotics, you likely can go home because you can take other meds and swallow. So it really depends where you're seeing these particular patients. They're hospitalized, they're severely ill, they're on IV antibiotics. Ideally, you want to get them out the door, put them on oral, and send them home. So that's kind of where we are. Now what I'm going to tell you is something very cool and different. This is an antibiotic that you've never heard of. It just came out in Canada a few months ago. We've been doing research with all new antibiotics, including this agent, for about 10 years. It is now available for practice. What I want you to know very simply is this antibiotic is one intravenous dose, and your patient is treated and cured of their skin soft tissue infection. And what I want you to take away is it has a long half-life. You give one dose, the drug has a very long half-life, so it's around for 2 weeks in the tissue, treating the infectious disease and rapidly eradicating the organism. I'll tell you a little bit about the properties about it, but then I'll talk about what role could this have in your practice in the setting of an antimicrobial stewardship program. So we've been working with all new antibiotics, including lipoglycopeptides. This is a review article we wrote many years ago, which included dalbavancin. Here we're showing you some of the other agents we studied. I'm going to show you only one structural figure. Don't fall asleep on me. What I'm showing you here is this is essentially vancomycin, but this yellow arrow, you've got this lipophilic tail on this drug. And what does that do? It confers upon it new properties. It has a slightly different mechanism than vanco, but why I'm showing you this, it's very rapidly, much more bactericidal than vancomycin. It kills all the agents that vanco does, staphylococci, MRSA, streptococci, enterococci very, very rapidly. When you ask yourself, what is the spectrum of activity of this drug? It compares similarly to vancomycin, to daptomycin, and to linezolid. The difference is it is much more rapidly bactericidal against these gram-positives like Staph aureus and MRSA, Staph epidermidis, streptococci, and enterococci as well. This is my worst slide. It'll get better from here, I promise. I'm showing you some of our own data here. We've been studying this drug for many years, and what I want you to get from it is the yellow. I want you to remember that the MIC90 is 0.06. So when someone says, well, how active is dalbavancin against these organisms? Your answer is it's very active, much more active than vanco, and the MIC is very, very low. Why I want you to remember 0.06 is because I'm going to show you the tissue levels of giving dalbavancin very shortly. And I'm going to compare the amount of drug in the tissue relative to the inhibitory activity to show you why clinically, once I show you the clinical data, it works so well. The other thing I want you to get from this is if you're susceptible to vancomycin, you're susceptible to dalbavancin. So in the lab, what we do is we measure vancomycin susceptibility as a surrogate marker for dalbavancin susceptibility. And that's what this study shows, is you can test for vancomycin, and if the bug is susceptible to vanco, it will be susceptible to dalbavancin. This is the magic of this drug, the pharmacokinetics. I will show you there are two ways to give the drug. The one I want you to remember is one dose, 1,500 milligrams. One dose and you're done. I'm showing you the maximum concentration in the blood. It's about 300. It's very highly protein bound. This is why it has such a very long half-life. And I want you to remember this. Dalbavancin half-life is about 2 weeks. What does that mean? You give a dose and the drug is around in the body, in the tissue, treating and curing that infection for a 2-week period. Remember the long half-life. If you're going to remember something about it, remember that it's a essentially supercharged vancomycin that kills pathogens quickly. It has a very long half-life, allowing one dose to treat patients with skin soft tissue infections. Excretion is good news. It's half renal, half non-renal. What does that mean? You do not adjust the dose if patients have creatinine clearance over 30, if they're on dialysis, or if they have mild, moderate hepatic impairment. It's the same dose. However, if the dose is less than 30 mLs per minute, GFR, then what you're going to do is you're going to drop the dose from 1,500 to 1,000. One dose and you're done. From a drug interaction perspective, I also want you to know it's not a substrate, not an inhibitor, and it does not induce the hepatic P450 enzymes. One of my last slides, then we're going to talk about clinical data. So this is me drawing. I asked you to remember that the MIC90 for dalbavancin for MRSA was 0.06. Here what I'm showing you is some data from Dr. Michael Dunn, and the work that they did is they looked at the pharmacokinetics of dalbavancin, and what I'm showing you here is the drug in the blood, the free drug. So the non-protein bound fraction, I'm peaking out about 20 in the blood. And what I want you to see is 2 weeks later, you still have 2 microgram per mL in the blood, meaning you're still way above the MIC in the blood. What about the tissue? I'm showing you the skin concentrations, the synovial fluid concentrations, the bone concentrations, and the epithelial lining fluid concentrations in the lung. What I want you to see here is you got a lot of drug in the tissue 2 weeks after you dose the drug. This is why when I show you the clinical data, the clinical cure rates for skin soft tissue infections are very high, but it's also been used off-label for bone infections, joint infections, endocarditis. vascular infections, device-related infections, anywhere where staphylococci and streptococci can cause infection. This drug has been used, one dose, and patients are cured. So you've survived the nuts and the bolts. Now let's talk about the clinical data. Clinical data was published in the New England Journal of Medicine. And I don't know how you are, but when I was trained, if it comes out in the New England Journal, you read it because it's going to change your practice the next day. In 35 years, our group has only published in this journal 3 times. So when it's in here, it's a big deal. The study was once weekly versus daily conventional therapy. So what does that mean? It was dalbavancin versus IV Vanco, step down to linezolid, because that's conventional therapy. The conclusion, and I'll show you the data shortly, once weekly intravenous dalbavancin was not inferior to Vanco, BID, stepping down to oral linezolid to treat acute bacterial skin and soft tissue infections. Oh, and by the way, dalbavancin was safer. That's another reason why it got into this journal. Little bit of data. I just want you to focus on my arrows. We're treating over 600 patients in each arm, and whether patients had cellulitis, that's a red arrow, major abscesses, another red arrow, traumatic wound or surgical site infections, another arrow. It was not different, non-inferior to vancomycin. And the yellow arrows, whether it was staph or MRSA or strep pyogenes, it was not different. What about patients who have malignancies? Unfortunately, as you know, the vast majority of the time in clinical trials, we exclude your patients from these clinical trials. So it's infuriating for you when you want to say, well, does it work in my patients if they have a malignancy? We exclude patients who are immunocompromised. We exclude patients who have malignancies. But in non-immunosuppressed patients, it is not inferior to vancomycin. And then the big study is the one I want you to look at with the yellow arrow. Researchers then went back and studied one dose of this drug. And that's what I want to focus on today. 1,500 milligram, one intravenous dose, and the patient's acute bacterial skin infections were done. And I'll show you a little bit of real world data on one dose, and you're done. And then I'll talk about the potential off-label uses for this drug, which likely could end up in your practice. So some good news, side effects. The drug is safe. Nausea, diarrhea, pruritus occurs, but it's much less likely to occur, any of the side effects compared to Vanco and linezolid. Nephrotoxicity, which I know you worry about, with Vanco is much less likely to occur with dalbavancin. And in fact, you do not need to monitor renal function, unlike vancomycin. You also don't do any therapeutic drug monitoring. We don't do levels for dalba. Allergy. One of the questions that comes up is, look, if I give you one dose and it's around for 2 weeks, what about if patients develop any kind of hypersensitivity reactions? There is no cross-reactivity with Vanco, first of all. If you're allergic to Vanco, you can still get dalba because the structure is different enough. I've been able to find one case of anaphylaxis with dalbavancin. The patient was treated symptomatically and did well. There are prior cases with patients that had hypersensitivity to Vanco, had received dalba and did very, very well. So there is no cross hypersensitivity. So let's talk about the real world. What is published on dalbavancin in the real world, since we have no published Canadian data? This is a paper talking about single dose dalbavancin and patient satisfaction in patients with acute bacterial skin and skin structure infections. 386 outpatients, 312 inpatients. The outpatients had major abscesses, traumatic wounds. Inpatients had cellulitis. To the best of my knowledge, none of these patients were immunocompromised with a malignancy. Then they looked at 14-day and 20-day outcome and showed that outpatients reported significantly greater convenience and satisfaction than being in the hospital. No surprise. Conclusion, one dose of dalbavancin, 1,500 milligrams, and you're done. is effective and safe to treat outpatients who have acute bacterial skin tract infections and need IV. It's safe and effective, and they're much happier when they're in an outpatient setting. Getting people out of hospital, as you know, getting them out of the emerge is a good idea. So what about infectious diseases? We have been talking about this drug a lot within the infectious disease community in Canada. And one of the major uses of this drug in Canada now is when patients come in to the emerge and they have a big abscess or cellulitis, and they are an injection drug user. And I'll show you a patient case, which has become a classical case of where the drug is now being used in Canada. And then I'll talk more about off-label use. So this is a 32-year-old female. She's an injection drug abuser, prefers crystal meth. She's homeless, underhoused. She comes to the emerge with a 3-day history of increasing pain and a swelling over the right side of her neck. And she's got a fever that's getting worse and worse and worse. So she comes into the emerge. She was assessed 2 weeks ago for this abscess. At that time, she got a dose of cefazolin, a gram Q8, 2 doses, pretty standard because you're thinking staphylococcus or strep. Then she's sent home on oral cephalexin, pretty standard. Emerge docs, as you know, love Ceflex. No blood cultures were collected at that time. Now she comes back in because things are getting worse. That's her mass. It looks like there could be some pus in there. What are you going to do? Typically in Canada at this point, you got a bunch of options, but IV Vanco in your patients, if they're compromised, you're thinking of combo E, probably IV Vanco with a gram-negative coverage, Piptazo, maybe Levo, maybe Ceftriaxone, maybe Meropenem, but typically non-immunocompromised, we go with IV Vanco because it covers staph, strep, and MRSA. Then she had a CT of her neck. She's got a thick loculated fluid collection, suggesting an abscess with overlying cellulitis. She's got a US guided aspiration, and you got 20 mLs of purulent fluid, sends it over to our lab. We're seeing lots of pus, which is a marker for inflammation and infection, gram-positive cocci, which is likely staphylococci. Empiric therapy, what are you worried about? You're worried about MRSA, you're worried about MSSA, but it could be strep pyogenes, unlikely to be MRSE, unlikely to be E. faecalis, but it could be also polymicrobial. So we're worried about MSSA, MRSA. If it's you and it's one of your patients who's complicated, I think you're also thinking gram negatives. I think you're thinking B and maybe some gram negatives like E. coli, Klebsiella pseudomonas, and potentially polymicrobial. So what did we do? We gave her Vanco. She grows out Staph aureus, and it's an MRSA. No surprise in this particular patient, likely a community-associated MRSA. She gets a couple of days of Vanco, and then she says, I'm leaving. I'm out of here. I'm still sick, but I'm leaving. At this point, what are your options? She's leaving. Do you refer her to the OPAT clinic and give her something else? Do you stick her on oral? Do you put in a PICC line? Our emerge docs don't want to put in a PICC line. You've got a lot of options in terms of what you can do over here. But this patient would be a wonderful candidate to put on intravenous dalbavancin. And the reason is 1 dose, she's out the door, there's no PICC line. You're going to cure that skin soft tissue infection, and you could potentially prevent the MRSA turning into an endocarditis. So in this case, we chose D, and this is what emerge docs with infectious diseases are doing in select cases now. No PICC line. If they need IV, sticking them on 1 dose of Dalba and you're done. So the takeaways, what are you worried about? Staph, streptococci in your patients. I would add in gram negative as well. Poor patient compliance. This is the time to consider within the stewardship program one of these long-acting agents like dalbavancin. But this is where a lot of the world is going in Canada, in the US. This drug has been around in the US and in many European countries for 6-7 years. It's just come to Canada now. And most parts of the world, it's used for skin infections, soft tissue, but also off-label. And I'll show you a little bit of this data. It's been used where the arrows are. Clinicians have used it for bone and joint infections, typically 1,500 milligram dose or two, one dose in 2 weeks, one dose today, one dose 2 weeks later. For bloodstream and vascular infections, it's typically been one dose. For endocarditis, it's typically been 2 doses, one today and another one in a couple of weeks. I'll show you a little bit of this data. The dosing on the left side, i.e. infectious endocarditis, typically has been 2 dosing, a dose of 1,500 now. That works for 2 weeks. You give another dose 2 weeks later, very high cure rates, as I'll show you. Complicated bloodstream, depending on what is happening, could be 1 dose, could be 2. Bone infections, there's a lot of success with 1 dose, but also with 2 doses, the osteoarticular infections. I'll show you a little bit of real world data. This is the summarizing of the data. Endocarditis, cure rates, 80%, bloodstream 80, bone and joint 80. And look at the resistance development. Very, very unlikely to occur despite these patients clinically failing vanco, daptomycin, and linezolid and being rescued with dalbavancin. This is a busy slide. Don't fall asleep on me. This is the Italian experience here. And what I want you to see is they're in the results, they're treating 50 patients with skin soft tissue infections. Patients also had osteoarticular infections, vascular graft, and cardiovascular implantable electronic devices. 98% clinical success. And what they're talking about here is getting them out of the hospital, going from vanco or dapto to 1 dose of dalbavancin, getting them out of the hospital, and concluding that the drug works, it's safe, you shorten the length of stay, and you save money because you get them out of the hospital. Experience from other countries, this is France, using dalbavancin. What are they doing? Indications, bone and joint infections, endocarditis, skin soft tissue infections, and these are gram-positive, Staph aureus, MRSA, maybe coagulase negative staph. In your patients empirically, I think you're also adding on gram-negative coverage because you're worried it could be an E. coli, Klebsiella pseudomonas, could be polymicrobial. You have gram-positive, gram-negative coverage. Culture, once you actually have a pathogen, likely it'll be a gram-positive. You can dump the gram-negative coverage and direct your therapy against that staph or streptococci. Other countries' experiences, this is osteomyelitis. And what I want you to see here is these are adults with osteomyelitis. In the results, 132 patients who received either dalbavancin or the standard of care. What's the standard of care? Intravenous vancomycin, and then eventually go into oral linezolid, or intravenous daptomycin, eventually going to linezolid. And what they showed is shorter length of hospital stay for dalbavancin and numerically less adverse effects. Conclusion, the drug worked. It was a 2-dose regimen here. 1,500 IV on day 1, another dose 2 weeks later, and their bone infection is cured and they're being treated in an outpatient setting. I'm almost done with off-label. 48 patients, bone infections, endocarditis, bacteremia, prosthetic joint infections, a lot of gram-positives like Staph aureus and MRSA. Conclusion, it's safe, it's effective, and you are saving money while you're getting people out of the hospital setting, and you're not giving them hospital-acquired infections like we frequently do in hospital. I'm almost done. What's the potential usage of this drug in Canada and potentially for you? I think this is primarily a drug that's going to be used by infectious diseases, but I think it's also going to be used in select cases by oncologists such as yourself, such as emergency room doctors, and potentially other specialists. The advantages of this drug are many. I'll talk about the limitations shortly. I like the fact that it's very rapidly bactericidal. I love that we've not been able to see resistance yet. I like the one dose and you're done. In select patients, one dose, you get them out of the hospital or get them out of the emerge, get them out of the clinic. I like the safety. I like you can give it over 30 minutes. I like the fact you don't have to monitor renal function or do serum levels, serum concentrations like with Vanco. I like the data off label for bone and joint and endocarditis and vascular prosthetic joint infections, and no drug interactions. What could its role potentially be in Canada? I think for infectious diseases and in the emerge, I think this is going to have an important role for select patients who you want to get the heck out of the emerge. And we've been focusing a lot on patients who are intravenous drug abusers, underhoused or homeless, and emerge docs don't want to put in a PICC line and send them home, or give them a PICC line, send them to an outpatient OPAT clinic. In select patients here where they need IV, one dose, out the door, and you know that their cellulitis, their abscess is treated, and potentially, if they've got a bacteremia, you may actually prevent endocarditis because you can successfully treat that bacteremia. Early discharge from hospital, which may pertain to you. You have a patient, you want to get them out of hospital. You've actually started broad spectrum therapy. You've got a culture. Now you know it's a gram-positive, a staph, MRSA, maybe a staph epi, one dose, and you can get them out of hospital and prevent them from getting a hospital-acquired infection while they're in the hospital. There's a lot of data out here getting patients out of hospital early. Lastly, when patients don't tolerate Vanco or Vanco hasn't worked, you could change over to this agent. And lastly, instead of Dapto for MRSA infections, I also think there's a lot of potential here for off-label usage to use it in select patients with bone infections and joint infections, endocarditis, catheter-related bacteremia, etc. But there are challenges. Anytime we have a new drug, people know very little about it. They're not really sure when to use it, how to use it. It's not in the guidelines. It's not on hospital formularies. With regard to lab testing, what are microbiologists like me doing? We test Vanco, and if it's susceptible to Vanco, it will be susceptible to dalbavancin. All new antibiotics are costly compared to generic older ones. So using it in the context of an antimicrobial stewardship program is critical. There's a lot of potential here for off-label need. I think we need some patience here. We need to learn about this drug in the Canadian context. We need more data in patients like yours who have malignancies. So what have we done? We've been studying with dalbavancin and its activity and have shown that it's outstandingly active against gram-positive pathogens causing skin soft tissue infections in the Canadian setting. We've also have a study called CLEAR, where we look at the usage of all new antimicrobials in Canada, and dalbavancin is in the CLEAR study. So clinicians, when they use dalbavancin, they hit a link, and in 3 minutes, they tell us why they've used it, how they use it, has it worked, was it safe? We have patients already entered in the CLEAR study, and this includes patients who've had vascular infections, skin soft tissue infections, other infections, one dose, and cure with no side effects. So we're learning, and we will be sharing our Canadian experience with the dalbavancin usage and sharing it with you. Let me summarize. We very frequently do not consider and highlight patients who have malignancies when we're looking at treatment of infections, including treating severe ABSSSI infections. We frequently exclude these patients from randomized comparative trials. So the data that is out there is typically case reports or case series. What are the pathogens that you are worrying about in your patients with skin soft tissue infections? I think because of the patients you see, you have to worry about both gram-positive organisms, Staph aureus, Streptococcus pyogenes, Strep agalactiae, but you also have to worry about the gram negatives, the enterics, E. coli, Klebsiella, and other enteric pathogens, even potentially Pseudomonas. So empirically, when your patients are severely ill, you're treating them intravenously, I think you're using combination therapy, something to cover gram positives, including MRSA, such as IV Vanco, something to cover gram negatives, piperacillin tazobactam, ceftriaxone, ceftazidime, levofloxacin, ciprofloxacin, meropenem, ertapenem, one of these agents that covers gram-negative bacilli as well. And then ideally, you're getting a culture, a swab, some pus to send it over to our lab, maybe a skin biopsy. You send it over to us and we will get you a microbiological diagnosis. Then what do? You de-escalate, ideally to the agent that it's susceptible to. And then ideally, the moment you can, you go on oral using one of your known oral trusted options. Challenges in ABSSSI is resistance, and also the fact that Vanco is not a great drug, lots of side effects, not very bactericidal, so we need new agents. I talked about this new drug. What I want you to know about is I don't think you're going to use this a lot, but I think you need to know about it. If you have a patient who has a skin soft tissue infection or potentially an off-label infection that involves gram-positives, Staph aureus, MRSA, coag-negative staph, and you want to get the patient out of hospital. They need IV, but you want them out of hospital. They need IV, but you want them out of the emerge. You can give one dose, 1,500 milligrams, and treatment is done. It's safe, it's effective, and I will continue to share dalbavancin data with you in terms of how are Canadian clinicians using this drug in the Canadian context. If you're interested in becoming a part of the CLEAR study, you just send me an email, say, put me into CLEAR. CLEAR is CLEAR, just stands for the Canadian Leadership Antimicrobial Usage Registry. We have all of the new IV antimicrobials there, and I'll send you the data every 2 to 3 months on how Canadian clinicians are using new drugs like IV ceftobiprole, IV ceftolozane tazo, IV fosfomycin, and also IV dalbavancin. So I'd love to stop there. And Vicky, I don't know if any of the clinicians have had a chance to chat. Maybe we have some comments, maybe we have some questions. I'd love to entertain any kind of questions or comments about any aspect of skin soft tissue infections, potentially other staph and streptococcus infections, old antibiotics, new antibiotics, oral agents, resistance, whatever you have on your mind. I'll stop there and thank you all so much for listening.